All right, so now I think we've got everything loaded up. And again, as with this morning, I have nothing to disclose in terms of any conflicts of interest. And we're going to talk today about really kind of the future of PAP therapy and some of the devices that are already available in that regard and what may be just around the bend. Some of the take-home points from this will be a little bit about the history when different types of new changes came about, the development of BiPAP and pressure relief algorithms, and what impact that had and the thinking behind that. But then also, we're going to look at what effect some of that had, including reducing the EPAP, which in effect destabilizes the airway, decreases the cross-sectional area of the pharynx, which increases resistance and flow limitation, and ultimately worsens sleep apnea. So again, we're talking about bilevel therapy there. The higher IPAP associated with traditional BiPAP actually cannot stabilize the airway. It actually just provides pressure support to increase the flow. If BiPAP and those pressure relief algorithms actually improved adherence, then this approach would have been beneficial, but they actually do not, okay? So what we're looking at is now intentionally reducing IPAP below EPAP, and that's not been previously described, but we want to see what effect that has in terms of efficacy and tolerability for patients. And there are a couple ways right now to do that, one of which is commercially available. That's why I put out there the visual aids with the VCOM device, and then we'll talk about other things to come. And what those do actually provide is increased comfort and thereby likely increased adherence. It provides the same therapy in terms of efficacy for treating OSA. And right now, primarily we're referring to uncomplicated OSA. We're not really referring to hypoventilation cases, things like that. And we'll talk about other correlates to using this therapy and some potential benefits, okay? So BiPAP was introduced in 1990, and that was developed by Mark Sanders, and this is the paper where that was introduced and brought out, because it was felt that by using BiPAP, that it would improve adherence, make people tolerate it much better, backing off on the EPAP and having a higher IPAP. However, studies have not really borne that out. Even going back to the 90s, we see that in studies, BiPAP failed to actually increase adherence and decrease adverse effects. In 1995, there was a study, again, looking at uncomplicated obstructive sleep apnea, where it backs that up. It did not show the increased adherence, and it did not show decreased adverse effects. And then there were further studies, including a Mayo study in 2014 and a more recent study in 2020, which confirmed this, okay? So despite little clinical evidence for using a device with an IPAP higher than an EPAP, it changed things financially. Obviously, there was more revenue generated for medical equipment companies and manufacturers of these devices, but that didn't really translate into effects for the patient, okay? Then we fast forward to 2003, and that's when Respironics introduced the first of the expiratory relief expiratory pressure relief technologies with C-Flex, and then the others came on later with Reslex and EPR. And these algorithms also were felt to increase adherence and likely benefit patients, be more tolerable. But again, in large randomized controlled trials, there was little evidence that it actually did increase adherence. And in fact, in a more recent study in 2016, it was shown that they may actually be associated with compromised therapy, right? Which, well, when you think about it, you just think, okay, well, if we're backing off on EPAP with these, and we know that EPAP is really what maintains patency of the airway, then that makes sense, okay? But another study in 2012 found that the pressure reductions may not even transmit to the pharynx, okay? And one problem with this is when you look at these, in development, they were engineered primarily to effects at the face, not to the pharynx. So that wasn't really tested. So over our history, we've not really been looking at the entire system. As providers, we tend to look at more everything from the face down to the lungs. As the engineers of devices and technology, we tend to think of things being static, and whatever transmits in terms of a pressure here is relevant, and from the device to the face is what is relevant. But we really need to be looking at the whole system, including from the device all the way to the lungs. And that's where we've fallen short. Then, next, in 2009, what came along were these mask compensation algorithms. Everybody remember when those kind of first came out and you started changing it on the device? And they have different appearances on the units, as you can see. And so essentially with the full face mask, you get no resistance. And then with the nasal pillows, you get a lot of resistance. And therefore, the increased pressure, the increases in pressure actually is less tolerable to the patient. So it may have the opposite effect of what we want. So in our practice, we actually set all machines to the full face mask setting. Patients prefer that little bit of pressure drop, okay? And as you can see with the masks, when you go from, oh, it doesn't show up. Okay, so anyway, as you go from left to right here, you can see you get increasing resistance with those different masks, going from the full face to the nasal mask, to the nasal pillows, and sequentially with each different decreasing size of nasal pillows. So in our practice, we tend to try to use masks with less resistance at lower pressures and more resistance at higher pressures. So these mask type settings, these mask compensation algorithms, they were actually never tested on patients. It was something that was engineered but not really evaluated using patients. And had we have done that, testing would have likely found that nearly all patients really actually prefer the full face mask setting, even with a nasal pillow interface. And we also would have found out that these also potentially compromise therapy. The belief was that maintaining IPAP was the priority in therapy. So if you use a nasal pillow mask, you build EPAP due to that increase in resistance, but using the nasal pillow setting basically does away with that and helps compromise your therapy. There was a study in 1992 that showed decreasing EPAP actually decreases cross-sectional area of the pharynx. And you can see that here where when you go from the top down of the imaging, baseline, then CPAP in the middle, and BiPAP at the bottom. And which one of those obviously has the largest cross-sectional area? It's the CPAP, the middle. Yeah, exactly. And then you see it over here on the graph where it's just shown in a different way, but you can see significantly this middle line, this is the CPAP, how much more cross-sectional area you have, and then it decreases again with a change to BiPAP. In 1994, there was a study by Levy, Papon, and Ferretti where they looked at and examined reducing EPAP with BiPAP and how it decreases the cross-sectional area of the pharynx. And they did find that indeed reducing EPAP reduces end expiratory cross-sectional area of the pharynx, okay, primary site, of course, for obstruction. Reducing EPAP also increased respiratory events. And then also, interestingly, they found that this end expiratory airway shape extends over into inspiration. In 1998, there was a series you can see here where decreasing EPAP was shown to increase flow limitation. So if you're looking at these graphs from the left going to the right, you start off at a BiPAP of 11/8, and you're sequentially increasing your EPAP up to what, even though it's a BiPAP, here you're at CPAP at 11, okay? And you can see down here, the third tracing, those are the airflows on each of those. So you can see how much more airflow limitation you have on the BiPAP with the lower EPAP versus the EPAP setting that's the same as IPAP and as a CPAP. So going on BiPAP not only decreases your cross-sectional area of your pharynx, but it also increases flow limitation. So, let's talk for a minute about IPAP before we completely discount that in any way. And we'll examine how IPAP works, okay? We know that by reducing EPAP, we can then increase IPAP and often treat hypopneas, right? So how does IPAP treat hypopneas? Well, there are two equations, one equation and another relationship that you have to keep in mind with regard to this, okay? And that's your change in pressure equals resistance times flow squared. And resistance is inversely proportional to area and diameter, okay? So how does IPAP treat hypopneas? There are really two possibilities. So one, is it that the IPAP is actually increasing the cross-sectional area of the pharynx? In order to do this, basically it would have to be reversing the resistance that the lower EPAP caused and increasing the airway size. Or is it that it indeed does not change the airway and it's merely just increasing the pressure gradient and therefore giving more driving pressure? So in looking at our formulas, we see that as resistance increases, flow decreases. And as diameter decreases, resistance increases, so therefore flow decreases, and therefore you get hypopneas, okay? So, of those two possibilities, we know, one, either we're increasing that cross-sectional area and decreasing resistance, or two, we're using pressure support to overcome resistance and restore flow. And what's the answer? The answer is all IPAP can do is actually give pressure support. It does not increase the cross-sectional area of the pharynx. Reducing EPAP reduces that cross-sectional area and the pharyngeal wall surface area. And since pressure equals force times the area, a higher EPAP would actually have less force to help open the airway. And another thing that we didn't really take into consideration is that the fact that the airway is actually viscoelastic. And what do I mean by this? So it's not just elastic. It doesn't go from one shape to the other instantly, like turning on a switch and off in terms of positioning. There's a time response. There's a little delay there. One way to think of it's like memory foam that's been deformed, right? So if you press on it, if you let go, it doesn't instantly pop back up, right? It takes time for it to eventually rise back up. So you keep doing that. So, and like most things, anatomically, most things are not a flip-flop switch. Some things can be, but not everything is. And it makes sense, right, that the airway has this viscoelasticity. And our previous airway models, like using the Starling resistor, did not take this into consideration. That was purely elastic. So it ignores that fact and does not take that into account. So all of this is why just increasing our IPAP does not eliminate hypopneas. And here's a little demonstration here. We're just kind of showing how the different pressures are transmitted, okay? And then you can see, so that balloon is like the IPAP bypassing the pharynx and going to the lungs, okay? And the IPAP, when it goes in, what does it change? It changes the most compliant part of the airway, which is what? The lungs, right? So it's not the pharynx. Versus with EPAP, when you're exhaling, you get more tracheal tug, you get more stiffness of that pharynx, and it helps maintain that patency, okay, with your EPAP. All right. So, let's also consider for a moment end expiratory lung volume. And you may say, well, why is that relevant per se? Well, it matters because this is really why the other therapies used for sleep apnea are really not as effective as PAP therapy, okay? So that includes, your oral appliances, your hypoglossal nerve stimulators, surgeries like the UPPP, and the pill that is coming out in the next year or two likely in terms of a medication in order to address sleep apnea. This is why all of you should have a lot of job security. PAP therapy will still remain the superior therapy, okay? Because what does it do? It maintains end expiratory lung volume. Back in 2005, 2006, Heinzer and his group found that manipulating the end expiratory lung volume with an iron lung could have significant effects on the AHI and actually the level of pressure required in order to maintain patency of the airway. And they found that by using that to allow for increased end expiratory lung volume, they could reduce the apnea-hypopnea index by half. So these people had their indices, and this is just by manipulating end expiratory lung volume. They found that the apnea-hypopnea index could go from over 60 to less than 30. Now think about that. Now this is not with PAP. This is just by manipulating end expiratory lung volume. And then they also looked at people on CPAP therapy. They looked at people on a pressure of 12, and by manipulating that end expiratory lung volume, by increasing the end expiratory lung volume, those people who are on a pressure of 12 then were found to only need a CPAP pressure of 5. And conversely, by doing the exact opposite and decreasing index expiratory lung volume, what did they find? They found instead of a pressure of 12, they needed a pressure of 17. Think about that difference between 5 to 17 just based off the index expiratory lung volumes and its effects. And it makes sense, right? So I mean, you think about that. You think about, we always have talked about, the abdominal girth and weight and how it can push up and affect lung volumes and things like that. So we know what effect that can have. So no question about it. And a study in 2012 also showed that index expiratory lung volumes can even predict severity of OSA. And then there was another study in 2010 by Stadler where they used an abdominal pneumatic cuff basically to compress the abdomen. And they found that with that, the more they increased that, the more it increased pharyngeal collapse, okay? And thereby, obviously, would lead to more obstruction. So, to sum up about optimal EPAP versus IPAP, the 4 primary advantages to using optimal EPAP are EPAP increases cross-sectional area of the pharynx. IPAP cannot. EPAP increases end expiratory lung volume, stiffening those pharyngeal walls, thereby preventing more collapse and more obstruction. And IPAP cannot. EPAP provides safety from rebreathing CO2. IPAP cannot. And EPAP also decreases the work of breathing, particularly in obese individuals, and increases the patient's own ability to generate their tidal volumes. And really the higher IPAPs being used really only assist with pressure support. All right, so now getting to our visual aids that everyone's got there. And if you don't have one, share with your neighbor there so everybody can look at that. So how many of you have already encountered VCOM, kind of used it, gotten any experience with it yet? Well, this is kind of the first step in testing the theory, if you will, okay, or it was. Now it's established as effective. And basically what this does is it adds non-compensated resistance. And there were a couple of stages in its development there back in 2021 and 2022. And then it was rolled out later in 2022 and has met FDA requirements and the patients began using. So basically VCOM was developed to try to decrease IPAP, okay? So how does it work? Again, it's a resistor. And you can see here on this graph, the dotted line down at the bottom, this is the VCOM tracing. So you can see down at low pressures, okay? So this is your pressure drop on this axis. Here is your flow. So down here at the low end, you can see that there's really no pressure drop, okay? But at the high flow, there's considerable pressure drop, all right? So you put the VCOM between the hose and the mask. You got your CPAP over to the side, and then obviously this is the patient. And then this is the VCOM here. And you basically breathe in, and then, so that tidal volume and the exhaust flow is coming from your device across the VCOM, and you get a pressure drop, okay? Then when you breathe out, the flow is coming from the patient. It does not cross the VCOM. Therefore, EPAP is preserved and you maintain therapy, okay? So VCOM softens peak inspiratory flow. So during inspiration, when the device generates both the exhaust flow and the tidal volume, and remember, flow in a PAP circuit is turbulent and not laminar, and the pressure changes actually by the square of the flow rate. That's that relationship that you saw. And VCOM exerts its effect during high inspiratory flow. Okay? During exhalation, flow is at its lowest, and so it's down at that low end of that graph, and has very little effect on EPAP, the VCOM. Okay, so you're maintaining therapy. Okay, and of course, as we know, our EPAP overcomes the increased upper airway resistance and the decreased cross-sectional area of the pharynx that lead up to obstructional events. Therefore, it splits the airway open, okay, and increases our functional residual capacity. So, okay. Are lower inspiratory pressures more comfortable for patients? This all raises this question. So, you know, all this may be great in theory, but how does it really translate into real life? So, a large regional durable medical equipment company based out of Michigan looked at 47 patients, and 98% felt that CPAP was more comfortable using the VCOM. Okay? Well, that's huge, especially, you know, if you're with a DME and you're trying to convince people to use this and they're complaining of, you know, because it's a new phenomenon, right? It's putting on a mask and having applied positive airway pressure when you're trying to sleep at night. So obviously that's an adjustment. And to be able to have people feel as though that's much more comfortable is huge, okay? And also at sleep centers in Middle Tennessee where this was developed, is actually my partner, Dr. William Noah. They looked at a study of 54 patients, and 51 out of the 54, or 94%, felt that they were more comfortable trying on CPAP just at a pressure of 12 during setup than without that, okay? So, and granted, you know, obviously we'll look at more numbers over time, but that's quite significant. This is looking at VCOM in long-term PAP users. Okay, and that's over a period of at least 3 months. They're averaging over 6 hours per night and without complaints. So these are people really that are doing well. Okay, they're not really having major issues. And they tried a VCOM for at least 4 consecutive nights. And even on people who are doing well, and you can see this is using 3 different types of CPAP devices, respectively for the Philips, ResMed, and React devices, 69%, 73%, and 83% preferred using the VCOM. Okay? And again, keep in mind, these are people who are doing well. Some of the comments that people are making, and this was a bit of a surprise, is a lot of people were saying, I love it. It makes the device quieter also. Okay? So, you know, I'm sure we've all come across an individual from time to time where they've said, you know, one thing I'd like is for the device to be as quiet as possible. So that's quite significant. And we're hearing that quite a bit. Some people are saying that they're getting a better seal with their mask with using this. It's easier to fall asleep. They just find the airflow more comfortable, or that they feel that it delivers the pressure more evenly. This is just some pictures of the next step in development, okay, and that is a prototype device incorporating the technology that's used, okay? So this is getting back to that, what is the future of PAP therapy? It's basically using that ability, and it's engineered to be able to reduce that IPAP pressure like that, because currently no device can. You know, of the BiPAP devices, you can have your IPAP higher than your EPAP, or you can vary that degree of pressure support, that difference between your IPAP and EPAP, or you can set the IPAP and EPAP the same and convert it into a CPAP. But no device currently is commercially available where you can actually decrease the IPAP less than the EPAP, okay? And so in some of the early studies looking at this, how much of a drop is comfortable? What are people finding happens to be the best setting? So this was looking at a pressure range of 1 to 6 in terms of how much inspiratory pressure drop you actually get. And these were people on CPAP at 8, 12, and 16 centimeters of water pressure. The N is the number of people in each arm. And at a pressure of 8, most people preferred a pressure that averaged about 2.5, 2.6. And then as you got higher on the pressure, it was upwards of around 4 or a little less, okay? So in terms of the average, usually they're in 1 centimeter increments. So, and you can see this involved male and female studies, and average BMI of 35, but ranging from 25 to 59. And an average AHI of 22.5. And you can see just here on the graph, this just shows at the different pressures on this axis on the bottom, CPAP pressures, the inspiratory drop that was preferred tended to increase a little bit with higher pressures, okay? Again, not dramatic changes, but significant in terms of that difference, okay? So probably, you know, it's going to be somewhere between 2 to 4 centimeters, something like that, that it actually drops, and that will be the typical preferred range. So the next question, logically, is will lower inspiratory pressures affect therapy? Okay? So don't forget, the VCOM only changes pressures based on this relationship, okay? As the flow increases, you get more pressure drop, okay? But it can't do more than that, it can't do less than that. There was a University of Utah study that looked at people on CPAP, which is the left side, the first 1/3 of the screen, versus people on CPAP with a VCOM. And so you can see on average with the VCOM up here with the pressure, it dropped that inspiratory pressure by about 2 centimeters roughly. But if you look at the bottom, you can see it did not cause events, even though you're having that pressure drop, okay? As far as safety data goes, we found that also VCOM does not adversely affect therapy. The P95 and P90 pressures remained unchanged. And this is looking at 61 subjects, okay? You can see there some were excluded for leak, but in looking at the P95, P90 pressures, the AHI and usage, N of 61, and with those P95s and P90 pressures, that was unchanged when you add the VCOM, okay? And interesting, look at the AHI. What happened there? it actually improved, right? So you can see, from the 1.79 versus the 2.15. So absolutely, certainly not inferior to CPAP alone in terms of that effect. And in fact showed a statistically significant improvement. In fact, 69% were improved. And also interestingly, usage went up. So again, we're talking about more comfortability with using this, and therefore people tended to use it longer. So on our prototype device, as you increase those changes, those pressure drops, okay, you can see here that this shows that the drop in IPAP maintained therapy, especially at pressure drops of the range of 1 to 4. And it also shows that we do need some EPAP, but lower levels likely are what actually help. Will lower inspiratory pressures decrease adverse effects? Because, obviously we've been after that for a long time, ever since the development of BiPAP back in 1990. That's what a lot of our efforts have gone toward, is trying to decrease a lot of the adverse effects, get people more compliant on therapy, and obviously decreasing long-term health risk in terms of those potential outcomes that untreated or undertreated sleep apnea can lead to. So, first of all, let's look at the use of chin straps and the need for those when using a VCOM. Well, VCOM substantially decreased the need for chin strap use during titration, okay? A very large number. This is an N of 1,684 patients. And it resolved the need for a chin strap in 68% of patients. So that's 68% that no longer needed a chin strap during titration. And obviously we all know everybody loves chin straps, right? So definitely huge benefit there. Has anyone ever been involved with a study where the patient during the night at some point said, "That's it, I can't tolerate anymore, I have to go, I'm sorry, that's the end"? Has that ever happened to anybody? Nobody? Yes, it definitely happens. It does happen. So in looking at the number of patients that had to abort their titration study, it reduced these by 91% by using this VCOM during their CPAP titration. Let's also consider something else, treatment emergent central sleep apnea. I'm sure we've all seen that over the years. And what we found is that lowering IPAP helps resolve TEXA during titration. So C-flex increases the occurrence of TEXA during PAP titration. And this shows here, with the C-flex on, that was present in 2.6%. With C-flex off, it was 0.3, okay? So again, we may be going backward with using that C-flex technology and expiratory pressure relief. Lower inspiratory pressure helps resolve TEXA based off studies not only out of sleep centers in Middle Tennessee, but also the University of Utah. And in 18 patients, 18 subjects, VCOM reduced those centrals and eliminated that TEXA with a central apnea index of less than 5 in all 18. So 18 out of 18 patients who had developed TEXA, VCOM was added and resolved the issue. Okay? And then in the other study, it was 17, or excuse me, in this study, it was 17 out of 17 on CPAP and the one patient on BiPAP also. TEXA is also more common with traditional BiPAP, as shown back in 2005 by Johnson, and C-Flex by Lowe in 2014. And you also see more of it typically at lower BMIs. So, it's certainly interesting. Is this just a coincidence that C-Flex was introduced in January 2003, and then TEXA, or what was primarily termed back then complex sleep apnea, was first described in 2005, shortly thereafter. So, interesting that it certainly appeared to be much more of an issue and much more of a problem after this development. All right. There are also many anecdotal reports of decreased aerophagia. Studies are pending in this area, but VCOM may indeed decrease aerophagia. I know certainly I've seen patients where they had this added to their circuit, and there were fewer complaints of aerophagia. Also, there's some early adherence data with the VCOM, and its effects seem to certainly be positive, with that large regional DME company in the Midwest reporting 12% more patients who met their 3-month Medicare criteria for adherence. Okay, and that's out of 100 patients. So quite significant when you can get 12% more people compliant with the therapy so that they can keep their CPAP and continue to use it. And then there's also another large regional durable medical equipment company in the Southeast that had 80 patients, and after 30 days in struggling patients, VCOM was added, and they found that the usage time in those patients more than doubled subsequently to that. So huge effects, no question about it, in a lot of people. So what about the AASM BiPAP titration guidelines? Well, obviously, we're going to have to revisit that and take a look at that and see, because all of this information really is quite significant, and hopefully will have considerable positive effects for patients. So again, some of our take-home points. BiPAP with IPAP greater than EPAP was introduced over 30 years ago now, with the hopes of improving adherence and decreasing adverse effects. Reducing EPAP with BiPAP increases airway resistance, worsens OSA, and the higher IPAP cannot reduce airway resistance. Using either the inline resistor, the VCOM, or the prototype PAP device to reduce IPAP and maintain EPAP, we found increased comfort, possibly adherence, equivalent therapy, potentially it may even be improved, but certainly it's equivalent therapy, and in several regards, reduced adverse effects in terms of leak, mouth opening, TEXA, and potentially aerophagia and noise as well. So you may say, okay, so what can be done now? We recommend setting the mask selection setting on the PAP devices to the full face mask setting, turning off the expiratory pressure relief settings on the different devices, and avoiding BiPAP in general, unless, and we're talking about for uncomplicated, straightforward obstructive sleep apnea, unless the pressure is above 20. Obviously, only a BiPAP device can go above 20. So obviously, you might have to use a BiPAP device if you're over 20 centimeters. And if patients have trouble exhaling, you can try a mask with less resistance. And then, of course, something we've all used for years is kind of lowering that CPAP setting initially, and then increasing the pressure sequentially as pressure tolerance develops. We can lower the inspiratory pressure to improve comfort, possibly adherence, and decrease adverse effects such as leak, mouth openings, texa, and potentially aerophagia using these new devices, the VCOM of which is already available. And that's currently the easiest and safest way to do that. And if need be, you can actually use even more than one VCOM in series. And then as pressure develops, as tolerance develops, you can sequentially remove the additional VCOMs. So, thank you very much for your time. I hope this was interesting and informative. Certainly, no question, we've got a lot of changes to come in the future with our PAP therapy and a lot of developments. So, and if everyone looks around, I tried to spread out some of the VCOMs. So if you've not seen one, you can see those. They're around on the tables. So share with your neighbor if there's not one in front of you there, so that everybody can see that. Yes, sir. This is strictly for, what I'm talking about now is for uncomplicated obstructive sleep apnea. So we're not talking about people with hypoventilation. We're not talking about restrictive lung disease. That's down the road. Obviously we want to see what this does in uncomplicated, straightforward obstructive sleep apnea. Yes, ma'am. Well, that's the next step. So there will be things coming. Always with technology, there's a bit of a delay. Obviously, you have to evaluate it and test it, and then the next step is that production phase. But yeah, we're excited about that and anticipate that coming next. Thank you very much.